All right. Again, thanks for joining us. My name's Natalie and I work in the marketing department here at Rothman. I hope everyone is doing well. Just a reminder to please keep yourself on mute so that there aren't any distractions during the presentation. And as you just heard, I will be recording the lecture and we will email it to everybody after tonight so that you have it for future reference. And again, if you have any questions during, please type them in the chat box at the bottom of the screen and Dr. Krueger will answer them at the end. So our speaker tonight is Dr. Chad Krueger, who is a fellowship-trained, board-certified orthopedic surgeon specializing in hip and knee replacement surgery. He served as an officer in the United States Army for 9 years while practicing orthopedic surgery. He completed his fellowship training in adult reconstruction right here at Rothman Orthopedics at Thomas Jefferson University Hospital. Dr. Krueger specializes in partial and total knee arthroplasty, as well as complex primary and revision arthroplasty of the hip and knee. He sees patients at our Abington, Willow Grove, and Chalfont offices. And he can take it away from here.
Thank you very much, Natalie. I appreciate everyone taking time to join me this evening. Hopefully you'll be able to gain a little bit of insight into hip and knee replacements from this lecture. I don't really have any firm disclosures for my talk outside. If you do hear some screaming or crying, it's because I've locked my kids out of my office so I can give the talk without them appearing in the background. So I apologize if you hear any banging on the door. So I definitely want to hear anyone's questions you have. So please go ahead and type it. Feel free, like Natalie mentioned, into the chat box during the presentation. I'll take time to answer them all at the end. One of the hardest things, sometimes talking to patients during COVID is that we aren't able to involve their families because of patient restrictions and so forth that we have now. So if you have any family members, they can certainly join the talk. And if this is something that you or your family members are considering, this would be a great time to ask some of those questions that you may not have been able to ask in person. So let's see. All right. So the first thing I really wanted to describe is just what is arthritis. So arthritis is the process when cartilage wears away within a joint, leading to inflammation and pain. You can see on the, I hope everyone can see my pointer, but this is a normal hip over here that has joint space between the acetabulum, which is the socket, and the femoral head, which is the ball. And this is a hip that has severe arthritis where there's no joint space. You can see the same thing for the knee on the right side, with the first knee with the blue arrows having a normal joint space, and then the red arrows demonstrating a lack of joint space. Cartilage is what allows joints to move without pain. And when that wears away, that's when the bones start to rub against each other, and that can lead to the quote unquote bone-on-bone arthritis. So arthritis in and of itself doesn't always cause pain, but the inflammation caused by that process does. So typically what we do is we try to alleviate those symptoms with anti-inflammatories, ice, and activity modification, along with some injections initially. But once those stop working, that's when we start talking about joint replacement. And that's when I'm going to spend the majority of my talk speaking to you about tonight. It's important to note that we don't simply treat x-rays. There are patients walking around that have very bad looking x-rays that have no pain. And those patients oftentimes are not a very good candidate for a joint replacement. It's hard to make someone feel better if they aren't having pain. Conversely, patients will have x-rays that don't show a lot of arthritis, that have tried everything and continue to have pain in their hip and knee. Oftentimes those patients will go on to get a joint replacement and do very well. So just because an x-ray may or may not show a certain severity of arthritis doesn't necessarily mean that you can or cannot get a joint replacement going forward. Again, we talked about some of the activity modification and anti-inflammatories that we'll try typically prior to doing more invasive things like injections. But eventually, when we get to patient selection and patients decide to move forward, we try to have a really frank conversation with patients in terms of who we think would benefit the most from this, okay? Oftentimes, talking patients out of surgery is much harder than offering surgery to patients. And some of that is because it comes down to patient expectations. We want to make sure someone has tried non-operative treatments. We want to make sure someone has arthritis on their radiographs, and then also figure out what your medical comorbidities are, and then what your expectations are. And one of the things that we certainly have certain criteria in our practice that are built into place so that we can help select the patients that we think will do best. One of those is for patients who are diabetic, we need their A1C to be less than 8. And although there are special circumstances sometimes that will allow us to take care of patients with an A1C above 8, the baseline is that anyone with an A1C above 8 which means their glucose is not well controlled, will not get offered a surgery until that is better controlled. It's the same thing with the BMI. If someone's BMI is above 40, we will not offer them surgery in this practice. And that's not because we're mean. It's not because we don't want to give those patients care that would likely improve their symptoms. It's simply because we don't want to put the patient into a position that they could get further harmed. And you can see this graph on this page showing the complication risks and deep infection risk for patients with certain BMIs. And you can see as you get to the right of that graph, it increases dramatically above 40. And that's why we have our cutoffs. So anytime a patient comes to see us here at Rothman, and if we tell them that they are not a good surgery candidate for a specific reason, we have evidence basing that reason. And we have within our practice itself, over 100 pages worth of documentation that we have gone through about 40 joint surgeons and come up with certain patient scenarios where if X, what do we recommend? And we look at the evidence and we come up with a clear definition of what we think is best in those situations. And that helps us keep our patients safe and also benefiting from the procedures instead of offering a patient that may be too high risk a procedure and then having something worse happen. Another thing that often comes up in the preoperative discussion is robotics. So patients often have the question, and we try to explain it to them quite quickly. But the bottom line is, even if you are getting a quote unquote robotic procedure, the surgeon is still doing the operation. And you can see an example of that here on the top right. There's also a difference between robotics and navigation, in the sense that in navigation, we're simply using a computer model to determine how to do things. Whereas in robotics, we're using an actual cutting device that will assist us in that regard, okay? Oftentimes robotics are used as a marketing, I'd say, are marketed, for lack of a better word, okay? However, we don't have any data in the hip and knee surgery to suggest that robotics actually lead to better improved outcomes for the majority of patients. There are certain patients who may benefit more from robotics than not, some of those with a more complex anatomy. However, for patients with relatively straightforward hip and knee replacements that are getting the procedure, there is no data to suggest that robotics work better than a surgeon. Now, some surgeons use robotics on a lot of their cases. Some surgeons use robotics on none of their cases. And I will tell you that there are very busy surgeons with excellent outcomes with both. So I want you to think about robotics kind of like a GPS system, okay? I think most of us have those in our cars or our phones now. And you may know how to get from one location to another location, but sometimes the GPS can give you different traffic patterns and things like that that you may be unaware of, okay? But if you're used to driving from point A to point B and you do it every day, you probably don't need a GPS system pulled up in your car to make that happen. And that's a rough analogy, but that's a general idea of kind of what robotics are. Now, I do offer robotic surgery in my practice. And again, I think it plays a very good role for certain operations in certain patients. But if I do not use robotics for every patient, because there are complications that can come from that as well. You can see the picture on the middle of the screen where you have pins going through extra sites that we have to place into your bone that we can use during the robotics cases. And those are just one more area where something could go wrong. The cases also take a little bit longer, which can increase your risk of infection, although very slightly it's possible. And it's one more thing, one more variable that you have in the OR. So again, I don't use it for all my patients. I will use it for some, but I don't think any patient should feel good or bad necessarily that they're getting robotics or not, because we don't have any data to suggest one way is better than the other. In terms of anesthesia, this is a common question that we get during the preoperative period as well. And all of us will try to recommend spinal anesthesia for our patients unless they have some type of underlying medical comorbidity or pathology that would prevent that from occurring, okay? So the reason we love spinal anesthesias is not because we enjoy having you getting stabbed in the back with a needle, all right? It's because it has less side effects, and it's a faster recovery. So, and there's a lot of data, again, supporting this, which is what we come up with all of our clinical practice guidelines based off of. Going to sleep is considered anesthesia, okay? But you are not with it when you have a spinal anesthesia as well. They give you other medications. I don't want you to think that you are wide awake in the operating room and just numb and unable to move. That's not how this goes. The spinal anesthesia simply allows us to decrease the amount of anesthetics required, okay? Oftentimes patients will want to know kind of what they will remember. And I will tell them that oftentimes they will be with it as they come into the OR, but after the surgery, they likely won't remember that. So it's a very common question. But again, this is the reason that we recommend spinal anesthesia is because it leads to the best outcomes. So that's why we do it. Partial knee replacements. So the indications for partial knee replacements are expanding, okay? And that is when we replace only part of the joint and not the entire joint, all right? Speaking specifically about the knee, and you can see the picture of that there, all right? One of the reasons that the indications are expanding is because some patients, if they're appropriately selected, can have better outcomes, faster recoveries, and state their knee feels a little bit more normal. Now, not every surgeon performs this procedure, so it's something that you should inquire about. But certainly most of us here at Rothman will offer partial knee replacements to patients that we think are good candidates. And again, if we don't think you're a good candidate for it, there is certainly a reason behind that. And it could be because of the amount of arthritis in the other areas of your knee or other medical comorbidities that may lead to a surgeon not thinking this is the best surgery for you. And to get to a total knee replacement, again, I've tried to think of some of the common questions that come up and kind of how we use the literature to give our patients the best results. I will say that the components that we are using now last much longer than what the ones you were using necessarily 30 years ago, okay? The main aspects that we've improved are not only the plastics, which is the part that sits between the two metal pieces in the knee, all right, but also the ingrowth surfaces and what connects the components to the bone itself. Some of those are based on cement, some are cementless, okay, and some are non-metal. It's for people who have severe metal allergies, and for those patients, we have specific implants that we can use for you if we think that the metal may be an issue for you. Now, we will often send patients to get tested for those nickel allergies or metal allergies, if you will, prior to undergoing the procedure. So this isn't something we're deciding in the OR, but those are the different options that are available. I will say that most surgeons tend to stick to one or two companies in terms of what they use. And the reason being is because if we don't have any data to suggest one company is better than the other, and every surgeon gets used to doing different procedures with different things. But you certainly want a surgeon who is used to doing the same thing over and over, and a team in the operating room who's doing the same thing over and over. And that's what we have here at Rothman Orthopedics, where we do, I think as a practice, over 12,000 joint replacements a year. In terms of total hip replacement, the main questions we get in the operating room are what type of approach will you use? And you can see the diagram that's a hip. You can see there in the blue, all right? So myself, I am mostly an anterior-based surgeon doing a direct anterior approach. Other surgeons in our practice are lateral, and other surgeons are posterior. Again, we don't have every surgeon is a little bit different, and each approach does have some differences between them. However, there is no data to suggest definitively that one approach is better than the other. There's benefits to each approach, okay? And you can see the difference. One of the differences being, if you were to get a posterior approach, you'd be laying on your side on the top, okay? If you're getting an anterior approach or a lateral-based approach, you're typically going to be lying supine. Now, certain surgeons will use a table like this for the anterior approach as well. Other surgeons don't need that for their anterior approach, and they can do it supine, okay? But when people wake up, they're typically a little bit confused about why they may hurt on their hip and why they may hurt at their knee. And you can see based on where you're positioning, that may be, that could be one of the reasons why. So asking your surgeon kind of what approach they do can be useful in that regard. And again, in terms of hip implants, I'm not going to get into the details outside of telling you that the plastics in the hip is what used to wear out a lot, and we've improved the plastics considerably. So the wear rates that we have now are much less than 1 millimeter per year, and they're probably about 1/10 of a millimeter per year, if that. So again, we would expect these plastics to last for a very long period of time. And although they only came out about 10 years or so ago, we don't have that long-term data, but based on all the testing we've done and everything we've seen so far, these plastics should last a long time. And that's allowed us to increase the opportunity to offer these procedures to patients who otherwise may have been too young to get them previously. So what happens during surgery, okay? Oftentimes people will wonder why they have bruising after their total knee, like in the picture in the middle here. Well, some of that may have to do with the fact that you had a tourniquet in place and all the blood kind of pooled distal to that tourniquet. Blood is just like water. All right, it follows gravity. So I can tell immediately post-op how patients are doing in terms of getting up and getting around, because if all the blood is if all the bruising is towards their butt, then I know they've been sitting. Whereas if all the bruising is down their leg, I know they've been standing. But you can expect some bruising. You're going to have some thigh pain if you have a tourniquet used on your knee. Some places don't use tourniquets. Some surgeons don't use tourniquets. And again, we don't have any data to suggest one way is better than the other. It really comes down to surgeon preference. Same thing with incision size. There was once a very big phase on having the smallest or minimally invasive procedures we could. And what we learned from the early adopters to that is that they actually had higher complications because they couldn't see things as well as they wanted. So now more people have gone back to the larger traditional incision. I like a small scar as much as anyone else, but more important than that, I want patients to know that I will make the scar as big as I need to, so I can make sure the surgery is done properly. Because I can get skin to heal much more reliably than I can have a knee function well if the components aren't placed well. I already mentioned the robotic pins. You can see down in the bottom left corner. Robotics do require sometimes extra pins placed through the femur and the tibia that wouldn't otherwise be there. And then a more common question that seems to be coming up in clinic, I'm not exactly sure why, I'm guessing it has to do with some type of marketing, is where do I cut the quadriceps tendon for my total knees? So I place that on the bottom right-hand corner here of the screen. You can see on the left side, this red line is a more typical approach, okay? That kind of comes down on the inside of the quadriceps tendon around the inside, but there are other approaches to the knee. Again, the bottom line is, it doesn't matter if you cut the quadriceps tendon or not. You have to get into the knee, and then you have to do the proper procedure in a good fashion, and then close the knee back up. We have no data to suggest one way is better than the other. Again, it is just surgeon differences that go on here. The positioning and so forth, I kind of talked about already, but wound closure is another thing that we have really tried to get up to times with, and which I think almost all of our surgeons are no longer using staples on the skin. Instead, we were using a dissolvable suture and then closing it with a glue. Okay, this is just one type of glue that's available on the skin. Not only is it more cosmetically appealing, it may make a difference in terms of wound complications in the short term as well. And again, we're doing that simply to try to give the patients the best outcome that we can. And this is kind of how that goes on. So in terms of recovery, okay, I think everyone's aware of all the newest literature and data looking at opioids. Every surgeon here hates opioids, and I don't say that loosely. We want patients to not be writhing in pain, and we understand they play a role in the recovery process. Having said that, they are a dangerous medication, and it does not take long before dependence can develop and addiction can set in. And certainly when you're doing an operation like a hip or knee replacement to try to improve someone's life, having that patient become addicted or dependent on opioids is the exact opposite of what that type of improvement would look like. So oftentimes for my patients, I'll let them know exactly how many narcotics they will be prescribed after the surgery. And I typically give around 30. And again, that's based on literature, okay? And if they go through those, I will let them know that they are not able to get another refill unless they come in and see me and I can figure out exactly what's going on. Because for most of my procedures, I expect that amount of medication to get them through. Every surgeon's a little bit different in terms of how many opioids they will provide. But again, I've seen it in too many people and too many patients. I don't want any of my patients getting addicted to opioids. So we use a lot of different non-narcotics to try to assist with pain control. And a lot of those are anti-inflammatories and other shorter acting modalities that we can give the patients both in the hospital and at home. Every one of the surgeons here wants their patients up and walking, all right? And we want you walking basically the day of surgery. Obviously, you're not going to be walking as far, and you'll be walking with physical therapy initially and nursing, but you can get up and start walking that same day. If you get done later in the day, it may not be till the next morning, but the point remains the same. These implants are placed in a manner so that we can actually have patients up and walking the day of surgery. Oftentimes people want to know how quick they can get back to work. It's typically around 6 to 8 weeks. Again, it depends on the surgeon and kind of what their, and also the patient's job. Sitting at a desk is going to be a little bit different than being a construction worker. and then driving. So we've done studies ourselves in addition to studies from other facilities that show most patients getting a hip and knee replacement can get back to driving in about 2 weeks. It may be a little bit different depending on if your left leg was operated on versus your right, but either way, the studies show around 2 weeks. None of us give anyone a driving test. So again, you got to kind of think like a lawyer in that regard, in terms of if you are still on narcotics and unable to bear weight fully on your leg, and then get into a car and have an accident, you're gonna have a hard time defending that type of action. Everyone gets perioperative antibiotics. And again, we've shown through a lot of research here how effective those can be. They will certainly get antibiotics before surgery, but they won't always get antibiotics after surgery, depending on if they go home. We've shown that the preoperative antibiotics matter the most, okay? And then one of the things that we often get asked questions about are, I have an allergy to penicillin that was discovered as a kid. I can't get our typical cefazolin, which is a penicillin-like drug. Well, we do know that most people who are reporting a penicillin allergy are not truly allergic. That's been studied. And we are happy to send patients for specific allergy testing if that is concerned. The reason we're so focused on that is because there is a growing body of literature showing that patients who don't receive cefazolin may be at a higher risk for an infection than patients who do. That's our preferred type of perioperative antibiotic. So it's something that I try to educate all my patients on, especially those who may have only had a rash or some type of stomach upset from penicillin before. Now, I will say that someone who tells me that they were anaphylactic secondary to penicillin, they're not going to get penicillin, and we'll come up with a different perioperative antibiotic regimen. But that's why we care so much about allergies and antibiotics used in the past. It's really because an infection is a devastating complication that we try to avoid as much as possible. In terms of spending the night at the hospital, we are certainly a rapid recovery practice. I would say the vast majority of patients spend one night in the hospital and go home the next day. Some patients want to go home the same day, and that's fine. Other patients will spend a couple days in the hospital, and that's fine too. We certainly don't kick anyone out, but we do want to help people get moving and back to life as quickly as possible, because again, that's the whole point of why we did the operation. In terms of what do we do now for blood clots? It used to be thought that we would give everyone either injections of blood thinners or warfarin, which is an oral type of blood thinner, or some other newer type of blood thinner that would take in a pill. Well, a lot of surgeons now, based on the literature that Rothman came out with, actually just give aspirin. If you don't have a previous history of blood clots, if you don't have any factors that would make you high risk for a blood clot, we found that one baby aspirin in the morning, one baby aspirin at night works just as well for most patients, and that's what we've gone to. It's easier for patients to take. It doesn't require needles, and the patients are doing very well with it. One of the issues with using too strong of blood thinners is that it can lead to more wound drainage, in addition to other complications that we try to avoid. And that's really I apologize if that was quick. I do want to open the floor up for questions. But I wanted to touch on different aspects of patient care that we tend to get questions about in terms of what are we doing and why are we doing it. So maybe I'll stop sharing my screen now, Natalie.
Yeah, sure. And Dr. Krueger, do you want to read the questions at the bottom?
Yeah, sure.
Of the chat, or I can read them for you?
Yeah, here I'll read them, and then that way I can answer them.
All right, and I did actually have two questions that people had emailed me, so I'm not sure if they're on, but maybe we can start with them and then we can.
Sure. Yeah, whatever you think is best.
All right. So the one question was, do you recommend Pilates reformer for post-hip replacement exercise? What about yoga?
So it's a great question. So that is the type of exercise we would typically recommend because it's low impact. Having said that, certain approaches and certain surgeons will have restrictions on in terms of what activities they want you to do immediately in the post-operative period. Every surgeon's a little bit different, but I'll tell you what I recommend. So I ask patients to take it easy, all right, whatever that necessarily means, but to do their daily activities that they would normally do for the first 3 months after surgery, all right? Some people were doing yoga and Pilates all the time, and that's fine. If that's what they want to get back to and they feel comfortable doing that within that 3-month period, that's okay. After 3 months, there's no restrictions at all for my patients. So if you want to start taking up something new and that you hadn't necessarily done before, I'll let you start trying that and working towards that. But that's kind of the general answer. So if your body's used to that type of thing, that's okay. Just check with your surgeon to make sure you aren't putting your leg or your hip in a position that they don't want you to be in the post-operative period.
All right, sounds good. And this was the next one. It's a little more involved, a little specific. So this may, if there's this really specific question, sometimes it may be better to come in for an appointment for a consult, but I will read this and see what you think, Dr. Krueger. So this person said, I'm 62 and was involved in a car accident in my mid-20s, breaking my patella and my femur, approximately 2 to 3 inches above my knee. It took 3 operations and 2 bone grafts to mend, 3.5 years, and I have been active since. He hikes, skis. He continues to have worsening arthritis and knee pain year after year to a point where it's causing his active lifestyle to suffer. Question: am I a candidate for a knee replacement with a break location so close to the knee joint?
Yeah, so the short answer is yes. And some of it obviously would depend on what the x-rays look like and what the previous scars look like in terms of what our surgical planning would be. But absolutely, if you have severe arthritis, which it sounds like you do, then you are a candidate for a knee replacement. And just because you may require us to plan a little bit more doesn't mean that we can't take care of you and give you an outcome that you would be just as happy with as someone who didn't have that type of traumatic history.
All right, sounds good. And then we have the questions in the chat box, and there's still a few that just came through, but the first one is, and you can read them off, but the first one starts at typical recovery period.
Yep. So again, I hold patients out of work for about 6 to 8 weeks typically. Okay. And again, some of it varies. It's patient specific, but that's a general idea. Our literature suggests that patients will continue to improve for up to a year after surgery. Now, that doesn't mean that you're not doing well much previous to that, but up to a year, you will continue to get better. So typically for knees, the first few weeks are painful and they can hurt and they take longer to recover from. And the pain lasts a little bit longer with knees. Total hips, the pain typically doesn't last as long. Either way, I see all my patients back at 6-week time frame, at which point they're mostly just walking in. They don't have any assisted devices, and they tend to be progressing quite well. So the vast majority of your recovery comes in the first 6 to 3 months, so 6 weeks to 3 months, but it can take up to a year to fully recover. In terms of I'll do the next question. I have outer knee pain as well as arthritis in the hip. Can the knee pain be coming from the hip? Yes, absolutely. So hip pain can be referred down the leg and make it seem like it's coming from the knee. So if that is very possible. So that's one of the reasons that we examine hips during our knee examinations as well, to make sure we aren't fooled. And if we're concerned, if someone came in for a knee pain, and we were concerned based on their examination that it could be coming from their hip, we'll get x-rays to double check that as well. In terms of what brands do I personally use? So I typically use either Zimmer or Stryker for my knee replacements. And then I will typically use Stryker or Smith & Nephew for my hip replacements. When it comes to, and those are for primaries. When it comes to revisions, anything's on the table. Every company has a little bit of a different portfolio in terms of what they offer. And that allows me to make a very patient-specific decision in terms of what implants I think are best. Let's see. How soon after total hip replacement can you sleep on your side? And will sleeping on the side cause the hip to dislocate? Sleeping on your side should not cause the hip to dislocate. In terms of how soon you can do so, some of it may depend on the approach. Again, I'm an anterior approach surgeon, so I don't have an incision over the side of your hip, so you may be able to sleep on your side pretty quickly. But it's all pain tolerance, regardless of what the approach is. If it doesn't hurt, you should feel comfortable doing it and feel safe knowing that you should not dislocate from that procedure or from that position. Double knee replacement versus one at a time. So in general, my indications for doing both knees or both hips at once, as opposed to in a staged fashion, which would be doing one hip or one knee and then waiting a few months and then doing the other one later, are typically a patient is under 65, without diabetes, and generally healthy, and then someone who I think can tolerate and has a support system to tolerate the operations. Bilateral knees certainly hurt. Having said that, if you have severe arthritis in both knees, it's not like you have a good knee to stand on. And the same thing with hips. So I will do bilateral total knees and total hip operations on patients, but I am pretty selective in terms of who I offer those to, because it certainly needs to be a teamwork at that point to make sure we have a successful outcome. PCL retaining surgery. Some surgeons will retain the PCL, other surgeons will not. I typically aim to retain the PCL for my knee replacements. Having said that, if the knee isn't balanced properly or the PCL is contracted into a position that makes me feel like the outcome of the surgery could be compromised, then I will remove the PCL. Most of the knee implants that are used today, you can use the same implants exactly, whether you save the PCL or not. And that's what a lot of surgeons kind of go towards. However, like I said, some surgeons are much more determined to save the PCL or to get rid of the PCL than others. I will say that I lean more towards saving the PCL than not, but I will tell intraoperatively sometimes I feel like it's in the best decision to remove the PCL. And if that's the case, I'll take care of the PCL. Because again, my goal is to give a patient a well-functioning knee or a well-functioning hip. So any specific step I have to take in the operating room to make that happen is what I'll do. And I think all the surgeons here would do the same thing. How soon before total knee replacement does patients start antibiotics? So you will get the antibiotics after you're at the hospital, before your surgery. So typically with vancomycin, it's within an hour of cutting the skin. With cefazolin, it's within 30 minutes of cutting the skin is what we aim for. So you don't have to worry about taking any of those at home. How are the kneecaps replaced? So kneecaps aren't always replaced. Some surgeons will do both. Some surgeons will leave the patella, which is the kneecap, unresurfaced, meaning they don't cut it and put plastic or metal on that. Some surgeons will cut the patella and place metal or plastic on that. Personally, I will make a decision intraoperatively, depending on what the patella looks like. If there's no cartilage wear on the patella, then I will oftentimes leave that patella as is, not resurface. If there is bad cartilage wear, then I will often resurface that patella and give it a plastic button. There are benefits of not resurfacing the patella are that you can cut down on any complications related to that resurfacing. Those don't happen very frequently, but when they do, they can be pretty devastating to a patient's outcome, such as a fracture or something along those lines. The downside of not resurfacing the patella is that some patients and some studies will report some anterior knee pain if they don't have the patella resurfaced. Again, the literature isn't very clear on if not resurfacing the patella is actually the cause of that. But it's really hard to tell patients that are having anterior knee pain, if they don't have a resurfaced patella, that the pain isn't coming from the kneecap itself. So again, those are very patient-specific discussions that I can have with any patients. Let's see. It sounds like we have 2 bad hips and a bad knee. Which one should I start with? Whichever one hurts you more. I will say hips tend to be a quicker recovery. So I think if all are hurting you equally, I would start with the hips and then work to the knee. And that way you can have 2 good hips to stand on before getting that knee replaced. High rate of revisions within a couple of years. Seems there's a high rate. I'm not sure what question specifically we're getting at. Certainly with my experience, I don't have a high rate of complications or revisions within the first couple of years. I will say that there are published studies showing that if you're going to have a complication, it tends to happen in the first year or 2 after the procedure. Once you get out past 3 to 5 years, it's very rare that people have significant complications. So maybe that's what the question was. If a patient requires an outpatient procedure unrelated to total knee replacement, how close can this be done? So the good question there. We will want most procedures to be separated by at least 3 months, if at all possible. Certainly emergencies arrive, and if that's the case, we'll rely on antibiotics to be given to help protect that knee or hip joint that we give. But if we can space them out 3 months or so, that would be great. Certainly with antibiotics, I think most people in the practice are giving antibiotics prophylactically for the first 2 years after a joint replacement. And then after that, letting the patients kind of choose what they'd like. Again, we don't have great data to support this one way or the other. Otherwise, we'd all have a very standard protocol. But I have no issues giving my patients antibiotics for the rest of their life prior to dental work if they like, simply because, I would fear an infection in my own knee if I had that replaced as well. So I respect that. How much radiation exposure from a CT scan for a robotic knee? This person said specifically from Stryker. So it's a low dose CT scan. It is not a high dose CT scan. I can't tell you the exact amount of radiation that is provided. I'd have to look on my chart at work to actually tell you that. But it is not like a normal CT scan. It is a low dose CT scan just so they can get the bone mapped out. ACL sparing surgeries. There are implants now, specifically from I think 3 companies that are ACL sparing in addition to being PCL sparing. For those of you who aren't aware, those are 2 ligaments that are in the center of the knee. Sometimes you can take them both out. Sometimes you'll take one out and leave the other. The other one that's typically left is the PCL, but there are implants that allow you to leave both. We don't have any data that suggests that leaving them both in makes anyone feel better or do better. I personally do not do ACL sparing surgery. So I honestly don't know of anyone in the area here that does either, but I personally don't do that. If prior ACL damage and arthritis have caused knock knee, will the knee replacement realign the joint? So yes, if you have a crooked knee in either one direction or the other, you can certainly do the knee replacement to align the joint. Personally, it's called a mechanical alignment because you're trying to get the leg straight. That is how I perform all my knees. So my goal is to have a knee straight. There are some instances where you'll choose to leave a degree or 2 of bend for one reason or another. But in general, I want my knee straight, and you're correct. That would knee replacement would align and straighten that joint. And then are antibiotics required prior to dental cleaning for total knee replacement? So yes, within the first 2 years, certainly within my practice, if you're within 2 years of getting your knee or hip replaced, I will ask that you take antibiotics prior to getting dental cleaning. Again, we're working on more data to support and come up with a clear answer for that. But the whole idea is we don't want that bacteria from your mouth getting into your bloodstream and affecting that knee joint. And then COVID concerns at the hospital. Great question. So we actually just submitted this study for publication that I was a part of. So we looked at all of our outpatient or all of our surgeries for hip and knee replacement since opening back up after COVID shut us down for I guess almost a month or 6 weeks or something along those lines. And the bottom line is our so we have protocols in place that prevents anyone who is showing symptoms that could be COVID from coming into our facilities. We have temperature checkpoints as well, so anyone has a fever would be turned away at the door. So we take great care to prevent patients who are showing any signs of COVID from coming into the hospital. Oftentimes we're asked about, well, what about asymptomatic patients that could have COVID? And that's a fair concern. If you are getting a knee or hip replaced, you will be tested with PCR, which is the COVID test, to see if you have the virus or not prior to getting your surgery and being admitted to the hospital. We do that for the safety of all of our patients in addition to the staff. Okay. When we looked at all the people who were asymptomatic and actually tested positive for COVID, it was 0.06%. So a very low number of patients who are coming in expecting to get surgery are testing positive for COVID. And again, we test everyone prior to coming into the hospital so that we don't accidentally give ourselves or expose ourselves to COVID or allow us to spread it to other patients. It's something we take great care about here because obviously that can lead to a lot of other problems, much significantly worse than the hip or knee arthritis it could be dealing with. Good questions, everyone.
Yeah, they were great. If anybody has any more questions, feel free to type them in. If not, I will be following up. And again, we did record this, so you will be able to reference it. And if there are any questions that you think of after we log off, feel free. You all have my email. Feel free to shoot me an email, and then I can always reach out to Dr. Krueger, and I'm sure he'd be happy to answer your questions if you think of anything after, and we can always follow up. How we do it? One more.
One more question. So how important is it to strengthen muscles before surgery? we want you to be as strong as you can before surgery. It certainly doesn't hurt to strengthen them before. Obviously, if your pain is preventing you from strengthening it, we understand that as well. So it won't prevent you from getting surgery, but certainly the stronger and more in shape you can be prior to surgery, the less road to recovery you'll have after surgery.
All right. Well, thank you, Dr. Krueger, and thank you everyone for joining us. Have a good
Yeah.
rest of your night.
Thank you. You as well. I appreciate it, Natalie.
All right. Thank you.
All right. Bye.